Good afternoon. Welcome back to Grand Rounds today. Today it's my pleasure to introduce actually co-presenters, Jolene Wolf and Kelly Flater, both clinical dietitians here at Mary Greeley Medical Center. The CME committee is quite appreciative of they're willing to present today. Topic is malnutrition, and particularly as it pertains to the hospitalized patient. And please join me in virtually welcoming Jolene and Kelly.
All right, so my name is Kelly Flater, and I will be getting us started with our talk on malnutrition. Our objectives today, we'll make sure everybody knows what malnutrition is. We'll define that, what kind of criteria we use to look when we're looking at patients, understand how prevalent it might be in the hospital setting, learn about how dietitians screen, identify, and treat our inpatients that have malnutrition. And then we'll also explore some ways that the interdisciplinary team can approach that treatment together. So for defining what malnutrition is, we do look to two different organizations that put together kind of a consensus criteria that we use for our documentation when we're diagnosing or identifying malnutrition in a hospitalized patient. So the first one is ASPEN, that is the American Society of Parenteral and Enteral Nutrition, and they have a set of suggested criteria and guidelines that we use to identify those patients in the hospital. And then there's this other group, a newer group called GLIM, and that's the Global Leadership Initiative on Malnutrition. That's actually made up of various groups from around the world that came together to come up with a more universal way to identify malnutrition in patients. And the funny thing is ASPEN is actually part of GLIM, so they did help come up with the criteria as well. But either set of criteria will work. And really the important part to remember is that it just takes two characteristics. So either criteria that you're following, you need at least two characteristics to identify malnutrition in a patient. So the type of characteristics that we look for, weight loss, inadequate oral intake, loss of fat mass or muscle mass, reduced functional strength, presence of edema, and then we can also look at inflammation in the body and the disease burden that the patient has. And how common are we going to see this in a hospital setting? Depending on the research that you're looking at, you might see a wide range of estimates for prevalence, just depending on what type of population you're looking at. But somewhere between 20 and 50% of hospital patients will have some degree of malnutrition, whether that's mild, moderate, or severe. From that, it's also estimated that less than 10% of those patients actually receive a malnutrition as their diagnosis. So what that means to really diagnose a malnutrition patient with malnutrition, you need an assessment and a note from the dietitian that lists the criteria, and then you also need a physician note that will list it in the problem list. So you need those two things. It matters for many reasons. Patients that are better nourished, they do have better outcomes. Outcomes that we look at are hospital length of stay and readmission rates. We also look at how well they do with treatments, how often they have to take breaks in treatments, how well they heal from wounds, things like that. So all of those outcomes we do see improvements in a more well-nourished patient. Malnutrition, it is more expensive. Those patients are more complex, and they tend to require more resources to take care of them. And I do have a couple studies that I'm going to go through just to kind of outline or highlight some of those benefits that we see when we address malnutrition. So this first study here, this was from a hospital that implemented a quality improvement project. They started doing a malnutrition screening tool where they screened all of their patients that were being admitted into the hospital. If they triggered positive for malnutrition, they automatically started oral nutrition supplements. So supplements were started within 24 hours of the patient being admitted to the hospital. They did this project for a year, and then they retrospectively looked back and kind of compared the differences between their intervention and what was going on before. So they looked at over 20,000 adult patient charts, looking at length of stay in the hospital and then 30-day readmission rates. And they saw really the significant difference that they saw was the length of stay of almost a day. So that knocks off 1 day off of that length of stay, which actually is it can save a lot of money for a hospital when you look at that long term over many patients. This next study that I have here, this looks at it more specific to a certain disease state. So this is malnourished patients that presented with acute heart failure. And this was a randomized trial, 120 patients that were randomized into a control group or an intervention group. That control group just received the conventional heart failure treatment. Intervention group got that same treatment, but then they also had individualized nutrition intervention, which included nutrition recommendations, nutrition counseling and follow-up, and they were provided with nutrition supplements that were appropriate for them. The outcomes that were monitored, and they followed these patients for about 12 months, but they looked at readmission rates with worsening heart failure, or if the patient passed away, they documented that as well. So what they found was the control group had a 60% rate of readmission with worsening heart failure or death compared to the intervention group that was at about 27%. So this study actually had a pretty good result with providing nutrition with it in terms of patient outcomes. This last study that I have to go through, this looks at more of the billing and coding that goes along with malnutrition and how the hospitals receive reimbursement for that. So kind of understanding how hospitals get reimbursed for patients, many hospitals will receive what we call a DRG type payment. And so that's a one lump sum per patient for the diagnosis for why they're being admitted to the hospital. And that amount doesn't change if they end up staying longer or if they end up having more tests or procedures done. So making sure that you really document kind of the complexity of the patient and why they're there becomes really important because that will change the DRG or how the patient is weighted and affects that payment that the hospital gets. So a malnutrition diagnosis, that helps kind of paint that picture of a more complex patient, which can kind of affect that DRG or that weighting of the payment for the hospital. So this study has an example from a community hospital that has 185 beds, but they did a review of a 3-month span where dietitians identified about 1,800 malnourished patients. And from those malnourished patients, 64 of them were not coded for malnutrition. So that means that there wasn't another physician note that listed it as a problem. So just the dietitian was addressing it. And from that 64% there, when they looked back at the charts and what was going on with those patients, they determined that about 40% of them may have benefited from actually having the coding or the malnutrition coding to go along with it to change that DRG to help give the hospital a bigger return on that patient because they were a more complex patient that took more resources. So just a few examples of how nutrition benefits both the patient and the healthcare facility. The next thing we'll go through is just looking at some lab values that might pertain to malnourished patients. Historically, albumin has been used a lot for identifying malnutrition, and what we're seeing now, there's a lot of literature that wants to take us away from that. And you won't see albumin or any lab values used as a criteria for like diagnosing or identifying malnutrition. I kind of look at it as more of a supporting evidence. So I'll still pull it into my notes and document it, but it's not going to be just because albumin is low, then this patient is malnourished. So lots of things that can affect albumin, like hydration status, disease states, inflammation in the body, things like that. So it's really a lab that you need to, I guess, interpret a little bit more. The next set of labs that I like to look at has to do with refeeding syndrome. And I like to direct people to ASPEN. That's that Society of Parenteral and Enteral Nutrition that also has the malnutrition guidelines. They have a nice, consensus recommendations for identifying patients that would be at risk for this and some guidelines for how to treat it or prevent it. But we look at those electrolyte abnormalities. So mainly phosphorus, magnesium, and potassium are the ones that we look at. And this happens when you start to refeed a patient too quickly. It results in shifts in these electrolytes and they can actually get really low and cause other problems. Can be fatal in severe cases. So the recommendation is to increase your feeding slowly and just monitor those electrolytes and replace them as needed. So it's more about how they change from one day to the next, not necessarily if it's normal or low. It's the change from what it was before, if that makes sense. Okay, now we're getting into kind of the standards for our nutrition support and how we do our workflow when we're working with a patient in the hospital. So we have clinical practice recommendations, and we do look to ASPEN for like workflow guidelines on how often we see patients and how to document. So they do have a nice pathway here that kind of outlines what you should do from admission to day of discharge. And actually, Jolene is going to pop up here next after me, and she's going to go through this a little bit more in depth. So I know it's hard to read on this small screen, but she'll take us through it a little bit more. All right. There you go.
Thank you, Kelly. I'm Jolene, and for any of you that have been around here for quite a while, you'll realize that I've been around here for quite a while as well. So it was fun for me to kind of think back of how far we've come in our clinical practice and tell you what we're doing now. When Kelly came on board a few years ago, we realized that the screening tool that we were using for nutrition was not a validated tool, and we needed to get an accurate, validated measure. So we did a little research and decided that the malnutrition screening tool was going to be a good option for us at Mary Greeley for a couple of reasons. One reason is that it is validated in the ambulatory care setting as well as the inpatient setting, and we do use it for both. And the other reason is it's a very simple tool, and like most facilities, our hospitals' nurses do the initial nutrition screening when they do a lot of other admission, and so they have to go through a lot of questions. It takes a lot of time, so we wanted it to be very simple for them. So we asked two questions. Have you recently lost weight without trying? And have you been eating poorly because of a decreased appetite? And if the score is 2 or higher, it's an automatic referral to us. This is actually what the tool looks like. It's in its original form, so you can see that for each increment of weight loss, you get more points. So it's not hard to get to 2 points or more. The wonderful thing about our EPIC system is the nurses don't have to actually put in a referral or score it at all. They just answer the questions, and EPIC does the rest and gets a referral right to us. So once we have a referral for malnutrition risk, we start what's called the nutrition care process. This is developed by our Academy of Nutrition and Dietetics, and it's fairly standard around the United States, if not the world. 4-step process, we do an assessment. Based on the assessment of that patient, we'll come up with a nutrition diagnosis, not a medical diagnosis. Then we'll decide what our intervention needs to be to help that patient. And if their patient stays here long enough, we can continue to monitor and evaluate to make sure that our intervention is working. So we'll start off with that assessment. This is probably the most time-consuming portion of that 4-stage process. We take dietetic interns from Iowa State at Mary Greeley, and I always have to make sure that our interns are seeing the big picture. We have to understand the patient's entire medical profile. Certainly you physicians out there and anyone working in the clinical world know that very rarely does a patient come in with one diagnosis that's not affected by some other problems that they have. They're usually a lot more complex than that. So we have to see the big picture. Then we need to assess their weight history. And again, EPIC is wonderful about that. We can do a dot phrase and pull in a bunch of weights to see how they've been doing. Then we'll assess barriers to oral intake. If they haven't been eating well, why aren't they? Why aren't they taking in enough? It could be a physical problem, like maybe they've got Parkinson's disease or a stroke and they've got too many tremors to get food to their mouth, or they're weak. Our occupational therapy friends can help us a lot with that, with maybe some built-up utensils or things to help make it easier. Sometimes patients have swallowing or chewing problems, maybe caused by a stroke or weakness. Our speech therapy friends can help us. Maybe the patient needs to do a chin tuck or have some altered textures. Maybe the patient has had some chemotherapy, radiation therapy, they're nauseated. We can get some medications on board, perhaps with that, or they've got some pain. So a bunch of reasons could be going on with that. So then we'll obtain a diet history, ask the patient, hey, what are you eating on a typical day? And this will give us some insight. From there, we will do a nutrition-focused physical exam. 30 years ago when I first came here, dietitians never touched patients. We were not allowed to touch patients. And now there are several spots on the body that we're looking for muscle and fat stores, so that's changed quite a bit. And then we will estimate needs using an appropriate formula. And I have to smile when I say appropriate formula. None of them out there are really very good, short of using a metabolic cart. None of them are 100% accurate, but they're a good starting point for us. And then we can follow weight along. If we start someone on a tube feeding or TPN and they're gaining too much or losing too much, we can alter the rate. So great to have a starting point. Kelly briefly mentioned the ASPEN Guidelines. So this is a copy of what it actually looks like. And you can see that there are kind of three causes of what they say malnutrition is, due to either acute illness or injury, chronic illness, or a social or environmental cause. And then there are 6 categories underneath for each. And remember that Kelly said you needed 2 criteria to have characteristics for a diagnosis of malnutrition. So any 2 of these 6 criteria will work. And it varies just a little bit, the weight loss, depending on time, whether it's a chronic or acute illness. The energy intake, you can see that's where when we ask patients what they're eating, this comes in. Or if the patient has been here long enough, we can see what they've been eating here at Mary Greeley. The body fat loss, the muscle wasting, that's where that nutrition-focused physical exam comes in. The edema, certainly we can come across and see some edema when we're doing our nutrition-focused physical exam. However, I'm going to be the first to tell you I'm not the best clinician when it comes to determining edema and what stages. So again, I use Epic as a tool. I'll put edema in the search bar and it'll pull in the physician notes and it'll tell me whether or not they've got edema and how much. So that's very helpful for that. The last one, the hand grip strength. Mary Greeley does own a couple of dynamometers that live in the therapy department. We have used them from time to time. It's a little bit of a limited tool, I think, in the inpatient world. We find that a lot of our malnourished patients are elderly and often a little bit confused, and so giving them directions on how to do it can be problematic. Often, again, they have other health conditions. Maybe they've got multiple sclerosis or they had a stroke, or so their hand might be weak, but it's not necessarily due to malnutrition. So we use that in kind of a limited basis. The GLIM guidelines, the newer guidelines that Kelly mentioned, have 2 categories as well, phenotypic or etiologic criteria. You must have one, at least one from each, to make a diagnosis of malnutrition. The unintended weight loss is just a little bit different than the ASPEN criteria, but in that kind of same ballpark figure. And then low body mass index, this is where we do actually use a little bit of a BMI. And you can see that if the patient is older, they're expected to be just a little bit heavier. So the criteria differs at the age of 70. The reduced muscle mass, that again is from that nutrition-focused physical exam, or some places have machines that they can determine that as well. The etiologic criteria is where that nutrition intake comes in, that diet history from the patient. And any chronic GI disorder, I'm thinking short bowel syndrome, high output ileostomy, those types of things can get pulled in. Kelly mentioned the inflammation, that albumin is a pretty good measure of inflammation, so we'll use it in that category, and also CRP we will pull in if that's elevated. It can be some inflammation. And then other disease states that are famous for inflammation, think rheumatoid arthritis being one. So we're not going to go through an entire nutrition-focused physical exam, but this is a good spotlight on a couple areas that are easy to see with our patients that are gowned up and have their hospital blankets pulled up around them. The first one is the temple region. And you can see from these pictures that it's a little bit subjective, and so that's why it's only one of the things that we use. But you can see the well-nourished patient doesn't have any scooping on their temple, where the person with mild, you can start to see just a little bit of a hollow area, and in the moderate, definitely you're seeing some scooping, and in the severe, more hollow. And I have had patients where I actually was able to stick an entire fingertip in. They had such a hollow, scooped area in their temple. And on the other side, you can see that we look at the clavicle as one of the areas, and in that well-nourished person, you can just barely see it. Mild, you can kind of start seeing that bone poking out. Moderate, definitely kind of some sunken areas, and severe, and I have definitely seen patients like this where you can just kind of see the tendons and everything attaching to that clavicle area. So then we go on to estimate nutrition needs, and trying to pick a formula that is pretty good. We'll base it on some different things. Has the patient had weight loss? Not everyone who's malnourished has had weight loss. Maybe they had weight loss 10 years ago and they've kind of been maintaining, but they still have malnutrition. Are they overweight? It is not a myth that you can have malnutrition and still be obese. I've had 300-pound patients that have lost 40 pounds in the last 3 months. Clearly they have malnutrition. Are they critically ill? Do they have some kind of a hypermetabolic state like cancer or wounds or a burn that we really need to think about increasing their needs and their intake? So for general, normal, healthy people without any major concerns, we're going to use that 20 to 25 cal per kilogram as a ballpark area. The RDA says 0.8 grams of protein per kilogram. If they've experienced significant weight loss, though, or they've got some medical concerns that are going to increase those protein needs, we're going to shoot more like for 30 to 35 cal per kilogram, and 1.2 all the way up to 2 grams of protein per kilogram of body weight. Then we throw in that monkey wrench of obesity. And for all 30 years that I've been a dietitian, there's been a lot of controversy about how do you estimate needs in an obese patient. The most recent bodies, the Journal of Parenteral and Enteral Nutrition and ASPEN and the Academy of Nutrition and Dietetics, are currently saying to go ahead and use their ideal body weight instead of their actual weight, and then use the criteria that we just talked about, or use their actual body weight and use 11 to 14 cals per kilogram of body weight. And I've calculated it both ways, and it usually comes out fairly similarly, because you just can't take a 400-pound person and use their actual body weight at 35 cal per kilogram, because you're going to come up with an astronomical number that's obviously not going to be accurate. I'll mention in the intensive care unit, when the pandemic hit, we had a lot of patients on ventilators, and again, ASPEN and the parenteral and enteral nutrition folks were saying, we don't want to overfeed these patients. We've always known our folks with respiratory problems, we don't want to overfeed them. So we tended to want to do hypocaloric. That's what the guidelines for COVID were telling us. But we didn't want to skimp on the protein because we don't want any of their lung and respiratory muscles weakening either. So we brought in a special critical care formula that's a 1 cal per mil, but is super high in protein. So we've been using that. So then we found out our patient is malnourished and we need to treat them and intervene in some way. And again, this takes a village. Dietitian, the first thing people think of is, oh, let's throw some snacks and some oral nutrition supplements at him. And certainly that is one of the first things that we do. With a caveat, I always cringe a little bit when I see oral nutrition supplement 3 times a day ordered. Because even if my patient kind of likes the oral nutrition supplement, after 2 days and 6 bottles of it, they're really tired of it and they never ever want to see it again. So I usually start off with more like 1 or 2. We have a lot more tools in our toolbox than just the standard liquid supplements. We have high protein gelatin. We have a high protein, high calorie ice cream. For the folks that don't like sweet things, we have a high protein chicken broth. And then don't forget about real food. Real food has protein and calories as well. Cheese and crackers, cottage cheese, yogurt, half a sandwich. For those patients that are willing to actually chew things, we can think about food as well. Diet education, a lot of these folks, Kelly mentioned the heart failure patients, they're on a low-salt diet, so we need to talk about that and how we get good nutrition on a special diet. Calorie counts, we don't do a ton of them at Mary Greeley, and I would say that the majority of the calorie counts that get ordered are for patients that we already know aren't eating well. It isn't really giving us any information that we don't already know. Where I do find it's valuable are these folks that we're maybe trying to wean off nutrition support. They're on a tube feeding or TPN, and we're trying to get them to eat a little bit more. And do we dare decrease it or end it altogether? Are they eating enough? So I find it valuable in that situation. Mary Greeley has a room service system, so patients order what they want when they want, but this is a problem for patients that really don't want to eat. So we will often get nursing family or just us involved to go ahead and schedule planned meals so that there is something coming automatically 3 times a day so that they don't just order a Jell-O and it gets missed. And for folks that we just can't make progress or enough progress for, or they truly cannot swallow or something, we're going to recommend nutrition support. Where our physician friends come into play is we really need you to help provide those medications to manage any nutrition impact symptoms, and there are a host of them. If patients are having diarrhea or constipation, nausea, vomiting, they really aren't going to want to eat. So medications that can help with those can certainly help with appetite a lot. Gut motility agents, something like Reglan for patients who just kind of feel like everything is stuck, can be a help. We can order tube feedings, but we need your blessing to do that. We can't order TPN. We can make recommendations, so we need your help on these kinds of things. And then I mentioned, it takes a village. So I mentioned speech therapy is very helpful for us. Occupational therapy, I mentioned, can be very helpful for patients. Physical therapy, just getting patients up and moving, can stimulate appetite, can stimulate the gut motility, and just make people feel like they're human again and want to eat. Our GI docs, if somebody's got an esophageal stricture or they've got some other GI issues, if they can help us, that's a real benefit. So it takes all of us. So we've done our intervention. Again, the average length of stay at Mary Greeley is 4-point-something days, so we don't always get to follow up for a long time, but we have a system in our policy that we make patients priority 1, 2, or 3. Our high-risk patients we're going to see every 1 to 3 days. We aren't physically here on the weekends, but we do take phone calls and we do come in as needed. Our medium-risk patients we'll see every 3 to 5 days at least. And for those patients that the nurses did the nutrition screen and they didn't have any identified nutrition problem, if they're still here in a week, we're going to see them again. And we also have team meetings Monday through Friday at Mary Greeley on all of our floors. And so really it's probably not going to take a week. If someone is having some nutrition problems, we're going to hear about it before then. All right, I am going to do a case study, and then Kelly is going to finish off with a case study. We've each had a patient recently that had a diagnosis of malnutrition. AA is an 85-year-old female. She came into the ER with a chief complaint of fatigue. And I'm sure the ER doctors roll their eyes when somebody comes into ER and says, I'm tired. But she hadn't seen a physician in 5 years. She was documented when they looked back at her records to be underweight chronically as far back as 2013. She came in with a height of 5'3" and a weight of only 65.5 pounds, giving her a BMI of 11.6. She was found to have hypertension and an elevated TSH, so I think that's what actually got her admitted to observation status. I mentioned that EPIC, we can pull in a weight history, so you can see that she had been chronically underweight and, in fact, had lost 10.5 pounds in those past 5 years that in the interim that we had records for. When I was an intern 30-plus years ago, I was taught that anything 65% of ideal body weight or under was not consistent with life. I don't know if that's really a statistical figure anymore, but I have that in my head from 30-plus years ago, and so it rang a lot of bells and whistles in my head that we really needed to get this woman help. And note that her serum albumin was 3.9. Kelly mentioned albumin is not a great indicator of just malnutrition, and this is a classic indicator. This woman is clearly malnourished, but her albumin is normal. She reported to me that she'd been trying to gain weight. She realized she was underweight. She was doing this by eating 3 healthy meals plus healthy snacks daily. Now, sometimes patients will tell dietitians what they think dietitians want to hear, but in probing a little bit further, I almost got the impression this woman could have qualified for a diagnosis of orthorexia. She was very, very focused on healthy food. So I had to talk to her about really focusing on just calories as a priority. I really didn't care where they came from. We just needed some concentrated calories to help her gain some weight. So this is her malnutrition assessment. Yes, she had unintentional weight loss. I did that nutrition-focused physical exam. I won't go through all of the criteria, but her eyes and her temple region were obvious. Her clavicle and acromion region, they were prominent and protruding. Her interosseous muscle was depressed, not a lot of muscle mass in her calf. So she definitely fit the criteria. I estimated her needs, and that 900 calories is a super low number, but that's 30 cal per kilogram. And again, we don't want to deal with refeeding syndrome. So we need to be careful with that and not start off too high. 1.5 grams of protein per kilogram came out to 45 grams. She was eating a good lunch. A lot of times patients, when I walk in, will push their lunch away, and it's an excuse not to eat, but she was very focused on finishing it. So she was willing to help herself. And so this was on February 11th. I talked to her about nutrition supplements, and she was actually very willing to try them. And she said, I think a couple times a day would be good. So that's what we decided to do. And notice that my goal is to prevent weight loss. We'd love to have people gain weight, but they usually aren't here long enough. So if we can just prevent weight loss, that's usually my goal here. She was on a low-sodium diet because, remember, she had hypertension. We talked about that a little bit. This is the next day. She's still at 65.5 pounds. And she actually liked the supplements and thought they were great. Since she was an observation patient, we both thought she was going to go home that day. We talked about where to find them, where to purchase them, because it was important that she continue some extra calories at home. And I was a little bit worried about her focus on healthy eating. The National Lipid Association has some great patient handouts. So I got her the one that talks about healthy eating if you are underweight, that focuses on a lot of the healthy oils and fats and things. Then I took a couple days off, went to see my granddaughters, came back on a Monday morning, and here she still was. I was kind of surprised to see her. Interestingly enough, she had been here long enough that she'd gained half a pound, so we were making some progress. She was continuing to enjoy the supplements. And the nurses were recording that she was eating 100%, and I take that with a grain of salt sometimes. Fortunately, our dietetic services system has Seaboard, which is their computer system, and I can go in and actually look and see exactly what they're ordering and how many calories and protein it's provided. Because sometimes the nurses will accurately record they ate 100%, but it might be pudding and Jell-O. So I went in to see just to make sure, and sure enough, she was ordering appropriately. So we decided to continue those supplements. She was a little bit teary. Come to find out, she had lost her husband recently, so I think she was really anxious about going home in a weakened state all by herself. So she really wanted to go to a skilled facility to get stronger just for a week or so. But she didn't medically meet criteria. And again, money was not an issue for her. She was willing to pay out of pocket. But interestingly, skilled nursing facilities are not anxious to have people pay out of pocket if they don't meet medical criteria. There's just too many hoops to jump through. So they said they would not take her. So the next morning, when we were going through our team meeting, I found out that she was indeed going to be discharged that day on the 17th at 1 o'clock. They had arranged to have home health services for her to make her feel more comfortable, make sure things were going well, and they'd arranged for Meals on Wheels for her. And at Mary Greeley, or in Story County, that's 7 days a week, which is awesome. I knew she'd be getting a well-balanced meal at least once a day. Hazel happened to be her nurse that day, and so she was worried that she was going to be mentally and physically exhausted by the time she got home. So she made sure that she had a good lunch here before she left, and she got dietetic services to bring over a sack lunch dinner for her to bring home. So all is well on that story, and I'll let Kelly talk about hers.
All right, so my case study here, this is a 63-year-old female. She was admitted to the hospital after a diagnosis of esophageal cancer with metastases. So she was coming in for the workup. She was having a speech evaluation and planning on a PEG tube placement. She did trigger for that malnutrition screening tool upon admission, so that was an over 2. Her admission weight, 116 pounds, height of 5'3", and actually a normal BMI, 20. So when I start my assessment, I look at that weight history. She didn't have a lot in her weight history, but it did go back at least a month, and I saw the month before she was 126 pounds. So 10-pound weight loss, which equals out to about 8% in the past month, which is actually severe. I think that's in the severe category. After I talked to her, she tells me that a normal body weight for her is 130 pounds, and she thinks she last weighed that much about 3 months ago. So per the patient report, I often will calculate that as well if I don't have enough information in the electronic health record. That's still about 10% weight loss in 3 months, which is still significant for the malnutrition. From there, I would do my nutrition-focused physical exam. So she did have multiple areas where it appeared that she had some fat loss and some muscle loss. And then I went through her intake with her as well. So her issue was she was having, esophageal cancer. She had a mass in her esophagus that was actually kind of obstructing from food going down very well, and it was to the point where she was having trouble with even thin liquids. So that's definitely a problem, and she was going to be seen by speech to kind of evaluate that as well. But for my note, my impression that I put was that she did meet the criteria for severe malnutrition, and I listed the criteria that meets that. So in my estimate for her needs, and I use this as well just for kind of recommending what her tube feeding rate and amount should be. So I start here. I always do a range that 30 to 35 calories per kilogram since she's had that weight loss, and 1.2 to 1.5 grams of protein per kilogram body weight as well. Speech did end up recommending her just to be NPO, and just everything will be through her tube feeding. So my intervention then is going to be the actual tube feeding. Typically, I start with a standard formula. The formulas that we have here are 1.2 cals per mil. And I like to start with a continuous rate just to gauge tolerance and see how they do, especially since her intake had been low for some time. I don't like to push the volume too much. That can cause some uncomfortableness in the stomach and the abdomen, and we'll just slowly increase from there if she's tolerating things well. At this point, I do start the referral process to get her set up for home supplies. So we have a little list of home supply companies that we go through with patients, and we decide on the right one, and I go ahead and make that referral process and make sure insurance covers everything for them. So after she has her PEG tube placed and feedings are started, I follow up with her, and she's reporting a little bit of abdominal discomfort and some trouble with leaking at her PEG site. So the GI doctors were called in to evaluate that leakage to see if there's anything they could do to kind of troubleshoot for her. And because of the abdominal pain, we actually reduced her tube feeding rate, took it down to 10 mils an hour with a plan to gradually increase every 8 hours as she's tolerating. So the next day, her tube feeding rate makes it up to 30 mils an hour. She's feeling like that is a good rate. She's feeling pretty well. So we're going to continue with the plan of slowly increasing until we reach that goal. Typically, after I get to that goal rate, I like to move them to more of a home routine, which I try to do like a bolus type syringe feed or a gravity feed with patients for home. And it's at this time that I do hear back from that home supply company that this patient will be covered 100% for her home supplies. So she won't have an out-of-pocket cost. So that's something that I communicate to the patient. Following up with her again the next day, her tube feeding is only at 40 mils an hour. So she's reporting continuing to have problems with some leakage. That is kind of making her not want to have it going all the time. So she had been requesting to have it paused and turned off. So at this point, we decide, maybe if she's getting close to being medically ready to go home, maybe we just try and get her on this bolus routine. She'll have some breaks in the day, just maybe that gastric emptying will give her some time, and this leaking thing won't be as much of a problem. So I adjust my nutrition support recommendation to a gravity bolus type routine. And so what I do is I take that total volume that we want for the day and I just divide it out into how many feedings they want to do during the day. I usually start with 4 feedings, trying to kind of mimic a normal mealtime routine that somebody might have at home. I also try and consider the kind of cartons that they get at home. They get little 8-ounce cartons or so. So I try and make a feeding to be 1 carton at a time or 1.5 cartons or 2 cartons. Try and make it kind of easy for them. So this 355 mils is like 1.5 cartons that she could do at a time. All right, then we get to the day of discharge. Her weight did go up a little bit, so 124. Probably some of that's going to be hydration. She may have been dehydrated upon presentation as well. The physician ended up adding a pro-motility agent just to help with that gastric emptying in hopes that this would help resolve some of that leaking problem. I go ahead and get the home supply company alerted of her discharge plan, and they make sure all of the supplies get shipped to her home, so everything's there when she gets home. And then she's going to need some outpatient follow-up as well. So I get her set up with outpatient nutrition counseling, so she has some follow-up, so somebody can help kind of troubleshoot and give her some guidance with that tube feeding once she gets home. So that's really important, making sure that care continues after they leave the hospital as well. So that brings us kind of to the end of our presentation here, really our important take-home messages. I have them here. So BMI, not a huge criteria. Really, anybody of any size can become malnourished. We do use that BMI as supporting evidence if it is very low. The lab values, again, there aren't really any that directly correlate or directly indicate to malnutrition, more supporting factors. Correct documentation matters to both the patient and the hospital. And really the biggest one that I want everybody to take away is that this is teamwork. It takes a village, like Jolene said, and the more people kind of getting involved with somebody's nutrition status, probably the more successful it's going to be. So with that, thank you for listening to us. And if anybody has any questions, we're happy to answer.
If anyone has questions, please type them into the box. Thank you.
Okay, well, it doesn't look like there are any questions. Feel free to contact us, though, privately or when you see us in the hospital if you have any questions. And thank you for listening.
Thank you.